My name is Václav Papež. I'm from University College London, from the Institute of Health Informatics, and recently we published a paper on transforming the UK Biobank to the OMOP Common Data Model for COVID-19 research into the Journal of American Medical Informatics Association. A little bit about background. Our work started under the Eden Rapid collaboration call, and we were there as a data partner with the access to the UK Biobank, which is a data set of health data from about 500,000 patients. And the data there is very heterogeneous, how to say it. There is baseline data, which is stored in more than or approximately 8,000 data fields. It uses proprietary dictionaries and vocabularies. There are electronic health records from primary care, from hospital care. There are data from mortality register, from cancer register. There is also data from COVID-19 measurements, and also genomic data, which wasn't part of our study in the end, but the rest of it was. And as you can see from all those brackets, every single sub-data source, let's say in UK Biobank, it uses different dictionaries, different vocabularies, sometimes standardized, sometimes proprietary, and all of this made our work very challenging in the end. And our main goal was to take this UK Biobank and converted it into the OMOP Common Data Model, specifically into the version 5.3. We were cooperating very closely with SME The Hive from the Netherlands, which stood behind the development of the ETL. As The Hive didn't have the direct access to our data, they had to develop the ETL on the synthetic data, which made all the process even more challenging, actually. But in the end, together we developed the syntactic mapping as well as semantic mapping. We were using already existing vocabularies from Athena repository, but we also had to develop our new bespoke mappings. And of course, the results of our work were very thoroughly tested, firstly via automated as well as manual test on the synthetic data. Then we executed testing tools like Odyssey, Achilles, or data quality dashboard, CDM inspection, so on. And finally, we applied series of predefined metrics, predefined phenotype algorithms on the source raw UK Biobank data and the target converted data, and we compared the results if they matched. So when I returned to the ETL workflow, it was basically developed in 3 steps. Firstly, we performed a scan of white rabbit profiling tool on the source data, and thanks to that we were able to create a synthetic data which the Hive uses for development of the ETL itself. They used the in-house pipeline framework or platform, let's say, Delphine, to develop the ETL itself. And then there was an iterative process when we took the ETL scripts, applied them on the real data, perform some validation, and based on that validation, we tweaked the ETL scripts, and we were iterating till we reach the satisfying results of the transformation. A little example how difficult it was sometimes to map the data. I grabbed one example from the UK Biobank baseline data, where one of those 8,000 fields was for non-cancer illnesses, and it was encoded via proprietary coding system, and its value, hypertension, was encoded by a proprietary coding system as well. So we had to first find it into the UK Biobank vocabulary accessible in Athena, but this vocabulary says nothing about it mapping from non-standard code to standard code. So then we had to develop via Usagi tool a mapping for both for the data field as well as for the value of the data field to reach the standard code. So, and this is just one of many data sources and one of many data fields. In the end, I'll go through this quickly because I'm running out of time. But in the end, we applied those predefined metrics. These metrics included demographic details, socioeconomic details, some health or lifestyle habits, some comorbidities and other kind of metrics. We apply them to the source data as well as to transform data and compare the results, and the same scripts or same approaches were applied to the COVID-19 positive subpopulation. So we compare those results, and in the end, we found that it was quite accurate. Totally, we mapped about 700 baseline data fields from those 8,000. We mapped about 3,000 values, all of those which are somehow related with COVID-19 research. We identified a small number of patients which were or we found a small number of patients which were identified by our phenotype definitions in converted data only, which is actually quite an interesting drawback. Unfortunately, it's for a bigger discussion, but we observe this issue with previous study as well. But in the end, it didn't affect the results massively. We transform almost all hospital care and primary care data, also the death events. Apart from those kind of data, which were using really proprietary coding system, from those we selected only such values which were COVID-19 related. From the DQD checks, just a really minority of checks failed. We investigate all of them, and in the end, it wasn't a big issue. Thanks to that, as we found our transformation quite successful, we were able to contribute into ASI studies. And as an outcome of those studies, one paper was already published. One is under review at the moment, sort of, and one is in a preparation and will be submitted for a review shortly. So we were very happy that we were able to contribute into those aggregated studies, which led to other publications. There is a lot of people and a lot of institutions and so on to which I would like to acknowledge, but mainly I would like to highlight the Hive team because it was amazing collaboration with them, fantastic management of the project from Erika, and great help from Spiros Denaxas about the study design. So it was fantastic to work with all of those people. And yeah, so a little bit more than 8 minutes.